Today, we're real excited as we celebrate Heart Health Month that we have two people from our cardiology department, and we have Sharol Plasterer and Denise
McDaniel.
And they have a great presentation, and without further ado, I'm turning it over to them.
What a great crowd. Can you guys hear me okay? Can you guys hear me okay?
No.
No. Because I can be very loud.
Yeah, it's all right.
Okay, how's that?
Keep it up.
Oh, okay. How's that? Well, my name is Sharol, and this is Denise, and we actually work in the cardiac cath lab. I started at Reid in 1984, and came to the cath lab about 21 years ago, and it's my passion. And Denise has been there since
8 years. It was
Yes.
8 years in January.
Yeah, 8 years
So-
in January. She is one of our top performers. She's kind of in line to take my job as the manager. So that's why I'm dragging her along to all of these things. So this is very low key, but a little interactive. You have true false paddles on your table. This is what I call ticker trivia. So you guys can participate. And you'll find that there is a pattern to the answers. I'm not going to tell you what the pattern is. You'll figure it out. If you have any questions, raise your hand, not your paddle. Or you can also just shout it out. And then at the end of the presentation, then we do have some equipment up here if you're interested. What does a stent look like? What does a balloon look like? What does a Watchman device look like? What does a cardiac valve look like? So you're welcome to come up after the presentation to look at everything, and we can explain it to you. So without further ado, so this is tidbits, ticker tidbits. The average adult heart beats 72 times a minute. True or false? True, that's true. A woman's heart typically beats faster than a man's. Yep, that's true. Good job, you guys. The average adult heart weighs 11 ounces. True. Are you getting the pattern to this? I'm going to throw a false in there, so be prepared. The average heart pumps 2,000 gallons of blood every day. It's a lot. A kitchen faucet would need to be turned on all the way for at least 45 years to equal the amount of blood that's pumped in our lifetime. Yep. Blood travels through 60,000 miles of blood vessels every day. I know, isn't that amazing? And the average heart pumps approximately 75 trillion, or feeds 75 trillion cells in our body. So the heart has its own electrical system. So we have plumbing and then we have electricity.
That's true.
Yes, that is true. Every day the heart creates enough energy to drive a truck 20 miles. That's true. A French physician invented the stethoscope in 1816. True or false? So here's the bonus question. Why did he invent a stethoscope? Because he felt uncomfortable putting his head against a large-breasted woman's chest. So he needed to invent something so he wouldn't be that personal and in their space.
Everybody should remember that.
In the 1930s, Dr. Werner Forsman invented the heart catheterization. This is true. He actually was a radiologist. He put a catheter in his arm. He ran down 2 flights of steps. He injected contrast or dye into his arm and took pictures of his heart. So when the hospital found out about this practice, which was not part of their normal practice, he got fired. Then 2 years later, he won the Nobel Peace Prize in medicine. So he could go booyah to his former employer, right? What year did Reid begin performing heart caths? 1991. That's when the Imperial heart catheterization opened at the old hospital down the street. Oh, I'm sorry, 1990. It was recognized with there was a plaque that says 1991. Sometime around there, long time ago. Last year, the hospital performed over 2,000 heart caths. And actually, we did over 1,000 percutaneous coronary interventions where a patient got a stent. In December 3rd, or on December 3rd, 1967, Dr. Bernard performed the first heart transplant. That is true. Heart disease is the #1 cause of death in the United States. Absolutely. Most people think that's false. They think it's cancer. But heart disease and the other complications that come with heart disease are what actually cause that number to be so high. Stroke, high blood pressure, kidney disease, that type of thing. Each year in the U.S., there are about 605,000 new heart attacks and 200,000 recurrent heart attacks. True or false? That's true. Yep. And actually, roughly every 40 seconds, somebody in the United States actually has a heart attack. It's very significant. Approximately 1,905 people will die every day from heart disease, not necessarily from a heart attack, but maybe from complications of either a heart attack or maybe because of a stroke, high blood pressure, that type of thing. A person is more likely to have a heart attack on Monday morning.
Yes.
Yeah, why is that? The stress of going to work in the cardiac cath lab. No, I mean, 85% of heart damage occurs within the first 2 hours of a heart attack. That's why it's so important when you recognize the signs and symptoms that you do not get your neighbor to drive you. You do not try to drive yourself. You call 911. Heart attack care actually begins before you get to the hospital. They can get an EKG on you. They can transmit it to the hospital. They can call the Cath Lab team in. The Cath Lab has 35 minutes to respond. So if you're 20 minutes away from the hospital, the Cath Lab team is going to be there maybe even before you get to the hospital, and they'll be waiting on you. So that's why it's important. Also, they'll be able to give you medication. They'll be able to monitor your vital signs. They'll be able to treat any kind of dysrhythmias that you might have. A lot of times people that actually pass away prior to coming to the hospital, if their neighbor, loved one, husband, significant other, whoever's driving them, they might have a cardiac event that causes their heart to stop beating. And so then they would basically pass away. Yes?
Are you staffed 24 hours?
Absolutely. 7 days a week, 24 hours. We've got 4 call teams. Phenomenal, phenomenal team.
And why was Monday the
Because of the stress of starting your work week. So-
And daylight savings time also.
Yes, daylight savings time? No.
It really does.
Risk factors. So we're going to talk about some risk factors next. And one of them is not being a Republican. I guess you guys can see that elephant right there. That doesn't make you at risk for having heart disease. That's right.
I'm going to scoot over here.
Risk factors can be divided into 2 categories. One of them are things that we can change, such as sedentary lifestyle, smoking, our diet, those type of things. And then the other things we can't change, the gender that we were born with, our age. So non-controllable, I think we just did kind of talk about this. Our age, family history, that's a big thing. So our genetic makeup, and then also the gender. And then as far as controllable risk factors, we did kind of talk about those. Smoking, high cholesterol, being able to treat your cholesterol effectively, your diet, sedentary lifestyle, high blood pressure, diabetes, illegal drug use, and stress. And I'm also going to add on there sleep. So you actually are at a higher risk for developing heart problems if you have a lack of sleep, so less than like 6 hours, 6 to 7 hours. I know that's a new kind of risk factor that they've actually kind of done a lot of studies with, so that you might be hearing more about that. As far as diabetes, if you get or have diabetes, remembering to try to keep those numbers in check. There's a lot of really good products out there now, such as like the little monitor that you wear that sends the information, real time to your phone so that you can monitor your blood sugar. And then as far as like illegal drug use, people that consume, you can tell that I know my drugs, but people that use cocaine, they snort cocaine, that puts them at a higher risk for cardiac spasm because it causes their heart muscle or their heart arteries to spasm down, and they can actually then develop a heart attack. Oh, excess alcohol. So 1 drink, I'm trying to think how many ounces, like maybe 4 ounces, like a glass of wine for a woman and 2 drinks for a man. Anything above that is considered excessive. So that's why we didn't serve wine today. No. Smoking tobacco emerged during religious ceremonies. Is this true or false? That is true. And then in the 1920s, many more women began to smoke because of the advertisements. My mom smoked. Did anybody else? Has anybody smoked? Yeah, so probably a lot of, maybe some people in here used to smoke, or they know somebody, or like their parents. Both my parents smoked when I was growing up. Smoking causes cancer. It lowers your LDL, which is your good cholesterol, or excuse me, your HDL, which is your good cholesterol, and it can cause narrowing of the heart arteries. So don't smoke. Cholesterol, is true or false? Cholesterol is an essential type of fat.
Yes.
Yes. It's actually found in our hormones. The recommended level for our total cholesterol is somewhere around 200 or less. And the daily recommended intake of cholesterol is roughly 300 milligrams or less. So what things do you think have high cholesterol? What? Meat. And meat, yeah, a lot of red meat. 40% of US adults are overweight or obese. And the American Heart Association recommends 150 minutes of exercise a week. And that's moderate exercise. This is not exercise. Clicking, doing the clicker. My husband thinks it is sometimes. 48% of US adults have high blood pressure. Nearly 20% of them do not recognize that they have high blood pressure. And that's a common problem, especially in lower socioeconomic groups, because they don't have access to health care. I think that we as a society are doing a much better job trying to reach those individuals and make sure that they recognize that they have high blood pressure, and then assisting them to get treatment. Only 1/3 of people with high blood pressure get treatment. Is that, no, a half, sorry. I'm looking through my bifocals. The American Heart Association recommends that our sodium intake be less than 1,500 milligrams a day. So when my father, he thought he was doing a really good job of eating well, because he was eating a lot of processed foods, like the TV dinners, until I showed him that the amount of cholesterol, excuse me, the amount of sodium in those processed foods is really high. The average adult consumes 4,000 milligrams of sodium a day. So be mindful of when you salt your food, and then also try to remember to read the packaging. People with diabetes have an increased risk of developing heart disease than those without diabetes. Is that true or false? That is true. 38% of US adults are pre-diabetic according to the CDC. So yes, that is true. Everybody needs to make sure that they're getting their sugars checked, their hemoglobin A1C on their annual physical. And then we kind of talked about this. Cocaine use can lead to a heart attack just because that medication actually causes vasoconstriction, or narrowing of the heart arteries. And stress can affect your heart. That looks like me on a Monday. And then once again, a glass of wine can be good, but just one glass, not one bottle. So now we're going to talk about heart attacks. So signs and symptoms of a heart attack. I guess I could ask you, but sometimes women have different signs and symptoms. They don't necessarily have that elephant sitting on their chest. Sometimes they have just a vague sense of something impending. They might have some shortness of breath. They might be fatigued, that type of thing. So recognizing the symptoms. But basically, chest pain, pressure, squeezing. You can develop chest pain. You can get some neck pain, some arm pain, even some arm numbness. Jaw pain, back pain, shortness of breath, nausea, anxiety, feeling of fullness. Those types of things can be indicative of potential heart problems. So you want to be able to recognize your symptoms. If you've got an upset stomach, you take an antacid or some over-the-counter medication and it doesn't get better, it gets worse, then you might want to think about, okay, what other symptoms am I having? Do I have risk factors that would put me at a higher risk for developing a heart attack? Approximately 30% of people having a heart attack die before they actually reach the hospital. These are the ones that get their husband or their wife or their neighbor to drive them, unfortunately. And just recently we did have somebody at Reid that passed away because his wife drove him to the hospital and he had an event in the car. So very passionate about this. So if you do experience any signs and symptoms, Like I said, you want to recognize your symptoms. You want to call 911 because, like I said, they can triage you based on your EKG. They have the ability to transmit that to the emergency room. The physician right there can look at your EKG. They will treat you with medication, start an IV, give you some oxygen, treat your symptoms, and then they'll put you on something, the little monitor down at the bottom that actually has the ability to defibrillate you if you were to go into a lethal rhythm. So the patient comes to the hospital, they're going to get a 12-lead EKG, and that's going to actually help to kind of triage them into what bucket do they fit in. Do they fit in what's called the STEMI bucket, which is the ST segment elevated MI. This patient is having an active heart attack. So we're going to take immediate steps to make sure that we get that artery open as soon as possible. Or if they don't have any EKG changes, but they're presenting with symptoms, they will probably be admitted and they'll be monitored. They monitor their EKG. We look at your blood results and then treat you for your pain. So the patient that comes in that's having a non-STEMI. So non-STEMI doesn't mean that you're not having a heart attack. You are having a heart attack. It just is not evident on the EKG. It's a non-ST segment elevated EKG. So basically, they're probably going to cool you off, give you some medication, serial EKGs, monitor your pain, treat you for your pain, and then you're going to come downstairs and generally have a heart cath with us. So who's had a heart cath? Is this personal? Can I ask that question? You don't have to answer.
They can volunteer.
Yeah, okay. So some people have had heart caths in the past. So basically what we're doing is we're putting in a catheter into the arterial system, either in the wrist or in the groin, and then they pass catheters up. When they actually engage the catheter into the coronary artery, the physician injects contrast and we can actually see what's going on with the heart. So you can see here that they can actually gain access in the wrist, which is very nice because you don't have to lay down as long and there are fewer complications. Or if they have to go through your groin, then you'll have to lay down a little bit longer. So this patient came downstairs. They're having their heart cath, a little challenged. So what we see here is this patient, they went through the groin. So you can see the purple catheter that's going up through the patient's groin and around their aortic arch. When the physician pops it into the opening of the coronary artery, this is the catheter, this is the coronary artery, he'll take a picture and we'll actually look to see if there's anything missing. So it looks like there's a bite taken out because really the lumen or the wall of the vessel should run right along there. So this patient definitely has some disease right here. The dark spot is where the contrast has mixed with the blood. The part that's missing, it almost looks like a bite has been taken out of it, that's where the plaque has formed on the wall of the vessel. So what the physician will do is he will put a tiny little wire down through that artery, and over that wire he can advance either a balloon or a stent. So in this first picture, he's actually advanced the balloon. He inflates the balloon pushes the plaque up against the vessel wall. He'll deflate that balloon, pull the balloon out, and then he'll go in with the stent. The stent is basically a metal mesh, kind of like a scaffolding. It is compressed over the balloon. When he inflates the balloon, it causes that stent to expand. The stent then gets pushed into the vessel wall and it holds that artery open. Any questions on that? So this patient then, unfortunately, has 100% block. The first patient that we saw did not have 100% blockage. He still had some blood that was able to get through, and we can see that because it filled these arteries down here and the branches of those arteries. This next patient, unfortunately, they have ST segment elevation. So this is the patient that's having 100% blockage. He's the patient that called 911, the EMS got there, they did a stat 12-lead EKG on him, and they diagnosed that this patient is having a heart attack. So sirens and lights are going, and the patients come into the emergency room. They'll do another 12-lead EKG, verify that it's not something, possibly different than a heart attack. With a heart attack, with the ST segment elevated heart attack, there's complete blockage. So there's nothing going downstream. So all of this muscle down here is dying. And the only thing that's being fed is everything up here. So it's like time is muscle. We have approximately 90 minutes from the time the patient hits the emergency room. And so this is data that we track. And so I think the last time I looked, We track it quarterly. I think our door to balloon, the national standard is 90 minutes and ours is less than 60. So we are rocking it. So this is a patient. Unfortunately, they have 100% blocked LAD. So here's the catheter, injecting contrast, and here's the blockage right here. And it looks like there's probably some blockage up there too. So this patient is definitely in dire straits, especially with this artery. So this patient's having severe chest pain, probably even having some what's called hemodynamic instability. Probably blood pressure is low. Patient might have a decreased level of consciousness because they're not perfusing blood to the brain. This patient's pretty sick. Once again, physician's going to put a wire down there, inflate that plaque, push that plaque out of the way, take the balloon out, then he's going to put the stent in there. And so this is the post-procedure. After they have the angioplasty, we can see that both those arteries, the left anterior descending and that left circumflex, are both now functioning and delivering much needed blood downstream. Oh, I think I already told you this. How many coronary interventions did we perform at Reid? Remember, we did about 2,000 heart caths. Does anybody remember? About 1,000. And since we started keeping the data, our numbers have grown every year. 2024 was the most that we'd ever done. And in January of 25, we actually exceeded what we did in January of 24. I mean, I don't know if that's a good thing or a bad thing. We're delivering good care, but it's unfortunate that our numbers are going up. But it's close to 1,000. The goal for reperfusion during a heart attack is 90 minutes. We did talk about that, and we're roughly about, oh, watch this. The next slide probably has the wrong data on it. Oh, no, it doesn't. Oh, the average door to balloon time? Oh, 53.3. We were a little bit this past quarter, maybe 56, but still a lot lower than 90 minutes for sure. I think that's it. Was that enough time? Who has questions?
Did you say you can show us what a catheter looks like?
Absolutely. And we have all kinds of equipment up here. Or do you want me to just pass around?
Point out and explain some of the things.
Yeah, absolutely. Yeah. So I don't know. So this is just basically a model of the heart. The coronary arteries actually lie on the outside of the heart with multiple projections feeding every cell in the myocardium or the heart. This allows, if you have extensive disease, this allows the physician or the surgeon to actually do bypass surgery. So they don't necessarily have to cut into your heart muscle. They just bypass the vessels on the outside of the heart. I don't know if you want to walk this around. Yeah. This is kind of a, yes?
Talking about you can have 2 drinks. Was that per day or per week or what?
It's yeah, two drinks a day. Yeah. So you can have 1 glass of wine in the evening. Yeah, women can. Good question. So this is what our normal coronary arteries look like. Actually, every artery in our body looks like this. 3 layers. The outside layer is very fibrous, keeps everything in check. The middle layer is muscular because as we're exercising, our body requires more oxygenated blood, so it's going to dilate. And then the inside is kind of like the skin, is what I call it. And what happens is, as that plaque builds up, it builds up between the skin layer and the muscle layer. And what actually generally will cause a heart attack is not that the plaque, and what I used to think, is that the plaque kind of grew together. That's not necessarily correct. What happens is you've got a plaque cap inside the artery and the blood is rushing across that cap. And so it can shear that cap off. All of that product spills downstream, but your body tries to seal that up because it thinks it's skin. And so it sends like all of the mediators that actually cause us to form a scab if we cut ourselves outside. So, but what happens is there's actually the formation of a blood clot inside of that artery. I think there was a picture of that. So the first one, the blood is rushing across. It actually disrupts that skin on that plaque cap. And then the body says, oh gosh, there's a break in the integrity of the skin. I have to put, I have to form a clot there. And so it sends all of these mediators there, platelets and red cells and thrombin, thrombinogen and all this stuff. And so basically it clots, but unfortunately it disrupts the blood flow downstream, and that's when we develop these symptoms. Yes, yes.
I want to know, do you have any information about the walk?
Watchman? Yes, I have an example of a watchman. I don't know that I have any written material. So she was asking about a watchman. So if you have atrial fibrillation, which is where the top part of your heart, those two chambers, quiver, you have an appendage, you have an appendage that actually hangs off of the left side of your heart, the top chamber. And what happens is that blood swirls in there and it clots. And then the clot comes out, goes down into the left ventricle and squirts back up into your brain. And that's how you develop a stroke. So patients that have atrial fibrillation, they generally need to be on an anticoagulant. But an anticoagulant like Coumadin, Eliquis, Pradaxa, those type of medications, they put you at a higher risk for bleeding. So if you have a history of nosebleeds or GI bleeds, or let's just say you're a rodeo clown, and you develop AFib, you love your job, but now you can't take an anticoagulant, so you're at a higher risk for bleeding. So I'm trying to think what year it is, 3 doctors skiing in Colorado at the bar, having their 1 drink a day. They wrote on a napkin, or I guess 2, they wrote on a napkin, they drew out the prototype for a watchman, and then they developed it and they sold it to Boston Scientific. I think it's right here. So this is what's called the watchman. It's this little parachute type thing, and I can walk this around, parachute type looking thing that has fabric on it. It sits inside, let's see if I can do this. This is your appendage. It'll sit right in here, and then tissue grows across that, and it decreases the risk for clot formation, basically making that down to a 0 because you kind of closed off that appendage. It does not cure your atrial fibrillation, but it does decrease the risk factors for you developing a stroke, and it allows you to come off of your anticoagulants. So then you can go back to being a rodeo clown, not have to worry about bleeding. I always thought that my heart arteries were as big as this. Here, you can walk that around, Denise. Denise will be my Vanna. Vanna's going to show you what I thought my coronary arteries look like. But in actuality, they're very small. The diameter is very small. Maybe up to 5 millimeters, and that's kind of an exception. Working in the lab all those years, I would say the mean millimeter diameter is about 3 millimeters. Not very big. Yes, tiny. And so it really doesn't take that much blood clot to actually cause those symptoms. Here's an example of the tiny wire that the physician has to maneuver down. Wow. It's just, it's real tiny, real tiny. And sometimes they will ask us, because we scrub in with them, we're holding the back end of the wire. Sometimes they ask us to load things onto the wire. Well, 20 years ago when I had better eyesight, I was good. Now it's like this. So, that is true though, but it's difficult. Most of the time, you do it by feel. I do this, I teach classes at Reid, and so I sometimes will give the nursing students or the girls on the floor, the nurses on the floor, I let them pretend like they're the doctor, and I give them a balloon and a wire. Okay, now load the balloon on the end of the wire, and it's very difficult. And then of course I pretend like I'm the patient. Oh, I'm having a heart attack. What's taking you so long? So this is a balloon, and what they'll do, just like that picture showed, is they'll take this device. They mix contrast in here because we never want to put air into a coronary artery. So they'll mix contrast or dye so that they can actually visualize this on the screen. And then they will inflate it. They put this down over that wire. This has not been in a patient. just to let you know. And so then they'll inflate that balloon, and you can see it's tiny.
Oh, yeah.
How tiny that is. Yeah. Now this is a small balloon.
Golly.
But yeah, very tiny. Come here, Vanna.
Yeah, very small.
Yeah.
we see the one that she just asked?
This one? Yeah, absolutely. So this is what I thought my arteries look like. No, they look like this. This is actually a stent for like the periphery. So yeah. So that's a coronary, and this one would probably go in a leg.
Okay, because I had one put in my leg.
Different sizes of balloons, and then here is the stent. Actually comes compressed on a balloon, and you can see that at the very end. There's a little metal thing. Yeah, so that's a stent that's compressed over the balloon. And so they slide this down, that tiny little wire, into place. And when they inflate the balloon, it then will cause that stent to expand. Now, a lot of people say, well, you know, if you have bypass surgery, or what if you get, you know, plaque develop in your stent, which you can, they can re-stent. I've seen one person that had 7 stents in one place. Wow. But every time they put a stent in, because there is mass to the stent, it's going to decrease that lumen. So sometimes it's better to do bypass surgery. So generally patients that have a lot, not if they're having an active heart attack, but if they come in as an outpatient and they have a lot of disease in multiple vessels, they might opt to send them for bypass because they do much better. But this is the stent on the end of a balloon.
A balloon is on the end of that?
Yeah, the balloon's underneath of the stent, so that when they inflate the balloon, causes that stent to expand. And it sticks into the vessel wall. They never take it out. Pretty nails.
Jolly good work, thank you.
I know. So that's a stent.
My husband's had a bypass.
Did he? Did he have stents before bypass? Yeah.
Quadruple bypass on St. Vincent's years ago, but he's
Yeah.
doing good.
Good. Yeah.
Age 3 is fine.
Yeah, my father-in-law did too. He was a physician, took very good care of himself. You know, he just had that genetic predisposition, unfortunately. My husband's had a couple of caths, and
They can do a lot with that.
yeah,
You'd be surprised.
absolutely, absolutely.
Basket that catches blood clots.
What's the what?
The basket,
Oh, it's called a Watchman.
the watchman.
Yes, uh-huh.
Because they used to, my mother had a clot, and she died with her clot. And they called it a basket. They wanted to put a basket in.
Oh, did she have a pulmonary
So
embolus?
she fell and broke her leg and developed a clot around her leg.
Okay, so
the
she
bone.
probably either had a fat embolism or that was probably in the venous system that went to her lungs.
Yeah.
So what they can do for that, I don't have an example, but they can actually put in what's called a filter.
Yes.
And that would sit in
So
there,
I
yes.
call it basket.
Yeah, it's basically a filter.
It was a filter.
Yep, you're fine.
What makes your blood 1 week the numbers are good and the next week it's high or?
If you're on Coumadin is so unpredictable. Yeah, so people that are on Coumadin, it's very unpredictable. A lot of food, especially green leafy vegetables, can really play a big part in maintaining a good number. That's why they came out with different medications now, where you don't have to have your blood checked every time. All right. How do I feel about what?
Salt substitutes.
Well, I'm not a dietitian, but I think that, you know, like the Mrs. Dash, my husband is a big salt person. I'm not, although I do like buttered popcorn at the movies, but we don't go to the movies as much as we used to. But I've not heard anything negative about salt substitutes. You know, most of it it's just seasoning. So,
Okay, thank you.
you're welcome. Yes.
Why in the world is Allergy so expensive?
That's a good question. So there are a lot of medications that are very expensive. It has to do with the amount of time that's put into the development of the drug and the amount of time, like a lot of these medications, it takes 10, 12, 15, 20 years to develop and to test and then to get FDA approval. So it does take a long time. But I know that you know, that's what the company has told me, you know, because that's one of the things. If you're on medication that is very expensive, a lot of those companies have some assistance. You know, I would just ask your pharmacist.
Oh, I did today.
Yeah?
They told me, call your insurance company.
Oh.
You're not gonna do anything.
Do you ever come out to the hospital? Do you know where the Cath Lab is located? The outpatient Cath Lab?
Can't say I do.
It's Suite 205 in the OCC, and we have some coupons, and it has numbers on there. So if you want to reach out to the company to see if you would qualify for a decreased prescription price, and then just pop on out. We'll get you one.
What was the room?
205, Suite 205.
Suite
Yeah.
205.
Yep.
Okay.
Yep. You're welcome. Questions? Yes. Oh, you want to see this?
So are all stents the same length?
No. Stents are different lengths and different diameters to meet the needs of the patient. We have some that go down to, so this one,
No, right here, just the end. So this is what stays in?
yep.
Okay.
And it tells you the name of the stent, and then it also tells you this is a 3 millimeter by 24 millimeter. So 3 millimeters in diameter and 20 millimeters long. And there's actually two different kinds of stents. There's what I call plain or peanut. So the plain one does not have a drug on the outside. And then there's another type that it's called a drug-eluting stent. What happens is they develop the drug-eluting stents to decrease the amount of tissue that grows inside of the stent itself. It's a big fancy word. It's called neointimal hyperproliferation because it's kind of like an overgrowth of skin. As the body heals, we develop a little scar. That's kind of just the overgrowth of skin. And basically, if you think about it, your coronary arteries don't have a lot of lumen or they're not very large. So any kind of overgrowth can actually decrease the amount of blood that's getting down there. So the drug actually eludes off. The drug is actually one that is used in cancer care. So what it does is it stops that cell cycle, and so you have a slower healing and you don't have that overgrowth.
Because I was going to say, how would it, but that just explained it.
Good. And then, let's see, this is the wire. This is the wire that has to go down. It has a nice little floppy end, but it's really tiny. It is very tiny, yes. Good questions. You guys have any questions over here? Yes.
I noticed the texture changes from here to, is it just stronger wire or?
Yeah, so this is a little more pliable. This is what allows them to actually push it into place. So this actually goes over that tiny little wire.
So they go side by side.
Yeah, it's like a monorail system is what it's called. So, yeah, so what the doctor will do is this part's sitting down in the coronary artery, so he then has to take this. Now this is bent on the end because it's been used so much, but he has to take this and he has to feed it on the back end of that wire. It's really hard.
Make you drink. Too bad they don't have a little thing like when you sew and you got.
I know, yeah, exactly.
It could take up to 15 minutes.
Does anybody else have any questions or want to see anything? This thing, so you can actually have, if you have soft plaque, then the physician can push that out of the way with just a balloon. If the plaque is there for a long time, it actually becomes what I think of as petrified or calcified. It's almost like hard wood. You can have different types of plaque. You can have fatty plaque, fibrous, calcified, which is like the hard kind, like petrified wood, or you can have necrotic, which is like dead tissue. So this device right here has a tiny little burr at the end of it that rotates about 165 revolutions, and it actually grinds plaque down into tiny little pieces that flow downstream in the heart, and your body uses something called phagocytosis to eat up all of that debris. So it's basically like filing that plaque.
Roto-rooter.
Absolutely, yes. And the first time that we did one of these procedures, I had no idea it was going to sound like you were at the dentist. Bzzz. I was ready to take the anti-anxiety medication instead of the patient because I'm like, that doesn't sound right. You shouldn't hear that kind of grinding noise, but you do.
Wow. Is that the end of that?
It's right here. You can kind of feel this little burr right there.
And what's that called?
This one is called this is called orbital atherectomy. So the first one that came out was rotational atherectomy. And so when one company makes something that is really good, then another company has to come out with something a little bit different. So this is the orbital. Either way, it's a little piece of tiny sandpaper that sits in there that actually grinds the plaque. Now it does not, it does something called differential cutting, so it does not disrupt healthy tissue, only like the calcified plaque. Yes?
If you had a examination
You can show them that.
and then 3 or 4 months later you passed, is that, and they said my son had an aneurysm.
An aneurysm?
Now, is there a different examination from one to the other?
Usually
Regular heartbeat.
an aneurysm. If somebody has an aneurysm, we can sometimes see that when we are doing a heart cath, depending on like where it's located.
So you're saying you need a special examination?
Generally what they'll do is they will do a CT, computerized tomography. So you'll have just basically an x-ray. And that looks at that actual pouch or the aneurysm.
Okay. Well, I had an aneurysm in my eye.
Right.
I didn't know that you could have one.
Yes, you can have an aneurysm in any
That's
vessel.
what I'm learning.
Yeah.
I'm learning.
Yep.
Yeah. And I was just literally stunned because the other eye was taking up
Doing all the hard work, huh?
doing hard work, and I just going along with the program.
Yep.
Yeah. So,
Good questions. Any other questions? I think that's really about it. We have, I can show you what a pacemaker looks like. So this is just a regular pacemaker. So if you don't need a shock box, if you do not have a lethal rhythm, or you are at increased risk for a lethal rhythm, and you just need help with your heartbeat, because maybe you have sick sinus syndrome or you've had other issues that have affected your heart conduction system, then they can implant a little pacemaker like this. Yes?
now, I have a pacemaker.
Uh-huh.
And I have a machine that's sitting on my dresser.
Right.
In my bedroom. I don't know what it's for.
That actually interrogates your device. So that way you don't have to go to the clinic and have them put a little machine over top of it to interrogate it. It's keeping an eye on your battery, because the more you use a pacemaker, the more it gets worn out, right? So it uses up your battery power. So if you don't use your pacemaker a lot, then your battery's going to last longer than if you are more dependent on your pacemaker to help initiate that cardiac beat.
So you're saying this will tell them, this machine that's sitting there, I don't know what it's for, this machine will tell the hospital,
Yes. Yep.
call Colleen and tell her get in here.
Possibly, yes. But it also looks at other things too. So making sure that everything is right with your pacemaker. Yes, question.
I didn't hear all of what you said when you said if you don't use your pacemaker.
So
Explain that, please.
So if you do not, so maybe you just have like, you're not dependent on your pacemaker to initiate your heart rhythm. So maybe when you go to sleep, your heart drops significantly that causes some problems, then maybe at night you would just use it, or if you're relaxed. But if your heart rate generally is above a certain rate, and they can program your pacemaker to kick in certain levels.
But you're making it sound to me like it's a selective thing, and it's not.
What do you mean?
When you say
Oh no, you can't turn it on and off.
that's what I'm saying.
No.
You make it sound
No,
misunderstood.
no, the battery. So what I'm saying is the more you use your pacemaker, the more your body requires your pacemaker.
body
Yes,
requires.
yes, sorry about that. And then this one is the one that has what's called the shock box in it. So this is much bigger. So this actually can analyze a rhythm, try to shock you out of that lethal rhythm.
Is that a dual? Is that what you're not talking about? The,
No, this is a dual chamber. Dual chamber means you have a pacemaker wire in your atrium as well as your ventricle. So this one has it has a pacemaker, it has a large wire that goes down into your ventricle, and it actually can deliver a shock. So if you've seen on TV where people get the shocks from the external paddle, this gives you an internal shock. So this would be for patients that go into a lethal rhythm that would cause them to die.
so then what's the dual? Because my husband has one, but it's a dual.
Dual
And they
just means it
told
has
him-
2 wires.
But does it do two? Okay, just 2 wires.
Yeah, a dual pacemaker, yeah. Now you can, so it depends on if your husband, now you can have a dual chamber ICD also,
No, it's not that.
yeah. So it's just a pacemaker, which just means that basically you've got a wire in your atrium and then you have that large wire that goes down to your ventricle. It can actually pace your ventricle, or it can shock you out of a lethal rhythm.
There you go.
Yeah. So if you've seen some of the like basketball, or even the gentleman that was like it was a Bengals player that he got hit and he went into VFib. So he probably ended up with this. So for young people that have what's called a long QT, a genetic predisposition that would put them at risk for having what's called ventricular tachycardia and dying, then they can implant these. And for young people, they generally will put them under the armpit because they're less noticeable as opposed to up in the chest. Now this technology has really come a long way, because when I was, now this is dating me, but I took care of a patient that had a pacemaker that was the size of a Kleenex box and it was in his belly. Back at me and Florence Nightingale. No, question, sorry.
When that plaque
Uh-huh.
is ground off, held down, do they send the material to the lab to find out what it is?
No,
No.
no, because they know it's calcified plaque, just cholesterol buildup.
Okay.
Yep.
I just wondered, because a lot of people I've been reading lately, a lot of women are afraid to take calcium supplements.
Right, because of that increased risk, especially carotid disease. Yes, yes. Yeah, I just had my wellness physical back in October, and my PCP and I were talking about that. So, good questions. Anybody else have a question? Yes.
On the one that shocks you,
Uh-huh.
are you aware that you got shocked? Like, do you feel something?
Yes, sometimes, yeah, so if the patient still remains conscious, they'll feel like they got kicked in the chest by a horse.
Oh my gosh.
Yeah,
Okay.
yeah. But they live to tell the tale.
Yeah. I just,
Not anything I want to experience, but I guess if it saves your life, right? All right. Anything else? You guys have been a very good audience and lots of good questions. Thank you for having me today. Everybody gets a swag bag because you all did so well on the true false. So we have a bag up here for everybody.
Thank both Sharol and Denise for a great presentation. And join us next month where we will talk about Alzheimer's and the Alzheimer's Association. Our guest speaker will be Kelly Cruz Nicholson, and a lot of you, she has a parent that has Alzheimer's, and so we look forward to hearing all about Alzheimer's from Kelly Cruz Nicholson. And make sure that you stop and grab a bag on your way out, and thank you for attending Heart Health Month.